we're going to move on to our hospital updates now, but I know you all have been sitting, at your desks. So now's the time, do a little stretch, a little downward dog, a little side bend to wake yourselves up and get yourselves ready for our local updates. And so this is, really important. It's for all of us to learn from each other and to see what's going on at the local level. So we're going to have 6 great presentations. And at the end of these presentations, we'll have a question and answer session. So up first, we'll be focused on prenatal engagement at Parkview Medical Center, and that will be presented by Danielle Smith, neonatologist here at the Anschutz Medical Campus, Associate Medical Director of the Children's Hospital NICU, and Medical Director of the NICU at Parker. So I'll let Danielle take it away. I think you're muted, Danielle.
Sorry about that. I'm in the hospital, so I don't want you guys to hear all the background noise. Okay, so thanks, Susan. So for the next 5 to 10 minutes, I just want to review some of the work that's been going on at over the last year, specifically at Parkview Medical Center. I'm going to start by giving a broad overview of what prenatal counseling looks like currently in the collaborative, and then we're going to focus on the work we've done at Parkview. And I want to say just a great thank you and give credit to Camille and the entire group at Parkview and at the Pueblo Public Health Community Center there, who've done a fantastic job in this area. Okay, so our first slide, this again is just overall data from the entire collaborative. So this is similar to what Susan had shown earlier. And what you see again is from the beginning when we started in 2017 through the most recent data that is September of this year. And we started at a baseline mean of about 5%, and we do have a new mean increase of 11%. The other thing that I think is helpful to look at is the trend over 2020. So we were actually seeing, I think, a nice uptick there in January through March, and then we've seen a steady decline. And similar to what Susan mentioned with some of our other concerns, I think one of the concerns specifically with prenatal counseling is the effect of COVID, and specifically accessibility, whether or not they're allowing inpatient visits for prenatal counseling. So that is a real challenge, as well as a lot of other challenges that individuals are facing in light of COVID with accessibility of care. So that's something we're going to have to keep a close eye on. Okay, next slide. So then this looks at the variability in prenatal counseling by hospital. And again, just as Susan mentioned in her introductory slides about the collaborative, we see a significant amount of variability. A couple of challenges in particular that have been highlighted already is the difficulty of getting data on prenatal and antenatal counseling. So the entire collaborative, the entire cohort, about 39%, so almost 40%, we simply don't have any data as to whether or not women are getting antenatal or prenatal counseling. And that's in the gray bars, and you can see it very significantly where some hospitals have no data available on prenatal counseling. Others, the vast majority of their data is unknown. And then we have other centers which have a very high percentage of data availability. So the first hospital, out of the entire cohort in that hospital, the over 90%, they actually have data available. So that affects, I think, a lot of our understanding and interpretation of what's actually going on. But then when we look at the six largest volume centers, which again is about 736 of the almost 1,000 patients, we see that prenatal counseling is occurring in about 60% of those larger hospitals, but still we have a large number of data that's unknown. And when we talk about next steps, we'll talk about that specifically. All right, next slide. So then we did focused interventions at Parkview Medical Center. And we started this work actually almost a year ago when we went out and did a actually, it might have been 2 years ago. We went out and did a site visit at Parkview and really started to talk about how we can capitalize and look at some more focused work at Parkview. So why did we choose Parkview? A couple of reasons. One, it is the largest single center in the collaborative, so that made sense. They have a very large population of infants and mothers affected in that area. The other thing that was unique is it's the only delivery hospital within the local area. So essentially within Pueblo and the surrounding area, it's the only delivery hospital, which really helps when we were trying to look at our data and some of our focused interventions, because one of the challenges that we have is, for example, in the Denver metro area, but even throughout the state, if you have multiple delivery hospitals in combination with multiple obstetrics groups, it's very hard to have any focused interventions because there's so many different individuals. The other thing that was unique about Parkview, and again, really speaks to some of the lessons that we learned there, is that Parkview partners very closely with the Pueblo Community Health Center. And that is the local community health center, which does obstetrical care, also provides medication-assisted treatment for women with substance use disorders. So in that setting, Parkview created an educational video. It was about 10 to 15 minutes long, and that video was created in a format that could be watched during the prenatal visit. So when moms were in the community health center for prenatal care, they were able to take 10, 12 minutes and watch this video. They created a process map or a structure so that the video could be viewed 2 times during pregnancy. So one around the 20-week visit, and then once again around the 32 to 34-week visit. So again, I think putting redundancy into the system certainly helped to improve access. And also the thought was that as women are approaching delivery, they may have other questions or concerns, and it made sense to have kind of a refresher. There also, again, was a very close coordination and referral process between the hospital and Pueblo Community Health Center. So after the women had viewed the video, they were given the option for an inpatient prenatal consultation if they chose. We'll see in a minute, COVID definitely affected that as far as the availability of in-person consultation. And then the final thing that we were able to do, and again, thanks to everybody down at Parkview and Pueblo Community Health Center, they were able to create a small patient satisfaction survey to really get some, although it's small, but some qualitative data to get a sense of what families thought about using this platform for education. I just saw something pop up in the chat just to let, and we can address this in the question and answer, but the educational video that Parkview created was specific to Parkview, but we do actually have a series of educational videos that were created by Illuminate specifically for prenatal counseling. So we can address that as well. Oh, sorry, next slide, please. So then this is Parkview specific data. So this again is the same period of time. So from April of 2017 through September of 2020. So a couple of things you see, their baseline, mean was about 2%. So, quite low. And then they've seen a significant increase beginning in 2019. Now have a new mean of 20%. So even though 20% still, seems low, I think, again, they should be commended for the significant improvement that they've shown. The other thing that I think is interesting is whereas within the larger cohort, we saw a steady decline in counseling between January of 2020 and September of 2020, Parkview has not seen this decline. So they have stayed, in the 26 to 30% range. So again, I think that's something to think about, that they've been able to adapt to some of the challenges presented by COVID-19 and still been able to maintain the same level of counseling. So, and these numbers include both prenatal counseling viewing the educational video as well as in-person counseling. All right, Next slide, and then we break down the numbers on this slide in a little bit more detail. So looking at September of 2019, so about a year. And this again, these are only patients from the Pueblo Community Health Center that were referred for prenatal counseling with the Parkview inpatient team. So they had 21 patients were referred for counseling. About 60% of them completed in-person counseling. And again, that speaks to a lot of we've talked about this before with a lot of the barriers on multiple levels for actually being able to access in-person prenatal counseling. So beginning in March of 2020, there was no in-person counseling because of COVID-19 restrictions. So they transitioned almost fully to video counseling. So they had 17 out of 19 patients were able to view the video during their prenatal care, and 9 of those individuals completed a survey, so about 50%. Next slide. And so then I wanted just to speak a couple of minutes on the patient satisfaction survey. And again, you can see that these are some of the main questions we asked was as far as if the video helped me better understand what to expect. Everybody agreed or strongly agreed. The next question was how people feel about learning the information from this video as well as they would have in face-to-face. This is obviously a difficult question because they don't really have anything to compare to, but this I think was realistic and showed some differences. About a little over half of people felt they were able to learn the information as well, and then others did not. Again, something to think about. And then we also asked what was the most memorable thing from the video, and 30% mentioned parents' role in caring for a baby during withdrawal, which again, I think one of the goals of prenatal counseling and education is really to empower parents in the care of their infant. So next slide. I'm just going to finish up quickly because I don't want to take up too much of everybody else's time. So next steps as far as prenatal counseling, we're going to build upon some of the great work that was done down in Pueblo and Parkview, and then also look at the larger collaborative. So the first thing is I think we're really going to start to look at how to reduce our number of unknown responses. And I think there's some discussion about that already. The other thing to look at in a little bit more detail is what is the relationship between prenatal care and prenatal counseling? So are we using the correct denominator? So first women have to be accessing prenatal care in order to be even eligible or approached about prenatal counseling. So we're going to begin looking at data on prenatal care, which has challenges as well. And then in addition to that, we've been thinking about looking at the relationship between maternal medication assisted treatment programs and prenatal counseling. So again, are women who are already in maternal or medication assisted treatment, that could be potentially a targeted population to ensure that at least, those women are receiving, prenatal counseling as well. And we've had challenges with collecting data for that, as well as, accessing or allowing those women to access prenatal education and counseling. So I'm going to go ahead and stop there. That was a very brief overview of what's been going on at Parkview, and then again, what we hope to be focusing on in the future.
Great, thank you so much, Danielle. Let's move on to hearing from Erica Weinmore, who is the medical director of the NICU at Lutheran and also a neonatologist here at the Anschutz campus. And she'll be talking about breastfeeding, specifically at Lutheran Medical Center. Erica, I think you're muted. Oh, we can't hear you, Erica. Let's give Erica another minute, and if she's having trouble connecting, then we can move on to the next presentation and come back to her. All right, let's come back to Erica while she reconnects. Jillian, if you can advance our slides to move on to Eat, Sleep, Console. I'd like to introduce Colleen Wheeler, who's a neonatal advanced practice provider She had been at the Denver Health NICU for some time and is now at the NICU at Lutheran Medical Center. And Colleen truly has become our state's ESC expert. And she'll be sharing with us some of the progress that's been made recently around ESC.
So Susan, Erica and I had sort of combined our slides. And so my slides are a continuation of hers, just because the breastfeeding update and the ESC updates sort of go hand in hand together of the efforts that we've put into place at Lutheran.
Oh, great. And I have Erica here in my office. She
okay, great.
Came right in. And so
great.
you can present from right here, Erica. You're all connected.
So apologize about that, you guys. Technical difficulties. Okay, well, thank you so much. Sorry for those issues. As Colleen was just saying, that we are both working together on a combination of ESC and breastfeeding initiatives at Lutheran Medical Center. So we're going to share some of our updates from that standpoint, and I'll give a little bit of a brief overview about some data that we have, as well as, excuse me, let me get myself oriented here. Other factors that we're considering in regards to eligibility for breastfeeding and safe breastfeeding initiation, and some of our experience of what we've been doing at Lutheran. We'll share some of our experiences with policy alignment and determining breastfeeding eligibility, how we approached communication and process mapping to try to help us overcome some of those challenges that we were having. And then finally, we'll share the development of our BPA, or the best practices alert, that Colleen's been working on, and she can share with you guys further. Next slide. So this does look somewhat familiar, as Susan presented some data in the data review earlier, but this is for our entire CHoSEN cohort among 439 infants who are eligible to receive mother's own milk. So our baseline mean eligible breastfeeding rates were 84% for the entire cohort, and really hovering around the low to mid 80 percentile. And while this is generous, there has been a slight downward trend in the past few quarters, as you can see. And I just want to echo, this is in relation to Susan's earlier statements, that monitoring this trend is ongoing. Next slide. But taking a deeper look into our CHoSEN specific data, we do see some racial differences in breastfeeding, as shown here, which has also been reported in previous reports across the country. Now, the top panel represents the breastfeeding rates for Hispanic mothers at 68%, compared to the lower panel for non-Hispanic white mothers at 88%. So clearly a great discrepancy there. And racial disparities in care in this area, as we have talked about previously today, is going to be a focus moving forward as the larger collaborative. Next slide. Other factors which may affect breastfeeding rates are safety and eligibility. Now, typically, opioid-exposed newborns may be ineligible to receive mother's own milk due to concomitant substance exposures in utero. As Susan referred to in her data review, our overall CHoSEN cohort of 1,023 infants, this table demonstrates the frequency of non-opioid co-exposures. Now, these are not mutually exclusive, but here we see that 1/3 of our mothers have methamphetamine exposure, 1/3 tobacco, 1/3 marijuana, among other substances that you can see listed here, though not all of these will lead to exclusion of breastfeeding. Next slide. Now, lastly, this is Lutheran specific data, with our top panel representing the number of OENs who are eligible for breastfeeding over time. And then the bottom panel shows how many actually did breastfeed. So the overall rate is 67%. And Cassie, this is, yeah, thank you, animated. Among those infants joining or in our CHoSEN collaborative at Lutheran. But the lightest bars here you can see represent yes to breastfeeding. And you can see, I think, a trend over time that we have an increase in breastfeeding at Lutheran over the last 4 quarters. So having briefly reviewed this data from our breastfeeding experience for the overall CHoSEN collaborative, then also just looking quickly at our breastfeeding data at Lutheran, we can see that we really want to improve our rates, but there's some other factors which are difficult to address, like racial disparities or prenatal substance exposure. However, one area that we can tackle is consistency within our hospitals with standard approaches, being aware of and reducing bias, and methods to improve communication. So this leads to where we started our work at our pilot site at Lutheran to improve breastfeeding rates. Next slide. So our first step was to identify and include our stakeholders, which mostly involved our current CHoSEN team members working on this initiative. Many of you are on the call today, but this includes our lactation consultants, case management. We have broad representation from nursing with our L&D nurses, our mom baby nurses, and our NICU nurses. And then also the provider group is quite large at Lutheran, and it consists of our core neonatal nurse practitioners, but then we also have 2 general pediatric practices, a large pediatric hospitalist group, as well as neonatology for babies who get admitted to the NICU. So we asked for invested and interested representatives from each of these groups, and we began by recognizing that we had several different policies which address breastfeeding and wanted to be sure they were up to date, but also consistency between the policies. Now, while the majority of Lutheran's delivery population consists of well-term newborns with breastfeeding as a hallmark of their care, we really wanted to emphasize safety as well. Next slide. So the very first step for our breastfeeding policy was changed to assessing an infant's eligibility for safe breastfeeding. And this assessment included 3 different areas for safety, the first being the infectious risk factors such as HIV or untreated TB or varicella exposure, and then contraindications due to maternal medications, and then maternal biological testing for illicit substances such as methamphetamine, cocaine, heroin, and marijuana exposure. Now, Lutheran utilizes universal screening for substance exposure for all delivery admissions, resulting in a urine toxicology sent on any mom who has a positive screen. Next slide. Now, once mothers have been identified as having some substance exposure, the recommendations are to allow them to pump and dump if they choose. We would encourage them to abstain from substance exposure. And then the pediatrician and case management team would meet with the mom to develop an individualized plan of care. Next slide. So we did experience a lot of challenges with this approach, such as how do we address moms on methadone with evidence of recent illicit substance exposure? Or how to address recency of use, such as if they have exposure within the week, what about 30 days ago? What about 3 months ago? And then how to advise mothers during hospitalization who have recent exposure, who want to breastfeed while you're in the hospital. And then the timing of determining this. But what we had to agree on first was that the first step was identifying an infant had been exposed and communicating this information to the pediatric team subsequently. Next slide. So this represents our process map that we developed to facilitate how we could best communicate substance exposure during pregnancy, that's revealed during the L&D intake, and subsequently giving that information to our postnatal team members on mom, baby, or in the NICU. So on the left side is the mother's workflow at L&D admission, and on the right side is the infant's workflow, with the white squares showing team members. So focusing on the left side, upon mom's admission, universal drug screen for drug use is done by the L&D team, and if positive, an order is placed for mother's urine toxicology testing with consent, and newborn cord toxicology testing is sent. A refusal to consent results in automatic newborn testing. And all of this is primarily done on the L&D side, but now as we move to the right side of the screen, looking at the infant's workflow, there's initial overlap among staff members where we have L&D nursing care overlapping with mom baby, as we are all familiar with this. It's probably pretty consistent across other hospitals. And the breastfeeding support is initiated right after birth. And cord and meconium testing is done or sent after delivery, and breastfeeding support is continued. So in the center of this diagram, we can see there are many opportunities for breastfeeding counseling to occur throughout mom's experience and hospitalization, and offered by many different team members from L&D nursing, mom baby nursing, and then also subsequently to the pediatrics team postnatally. The challenge we found was that the individualized plan developed with a pediatrician oftentimes didn't occur until later in the infant's workflow, and that breastfeeding had already been initiated. Next slide. So while the process map was really difficult to construct, it was so important in that it allowed us to voice and identify numerous challenges. The timing to feed the infant. When and who educates mom regarding safety of breastfeeding and determines eligibility? Conflicts for nurses who are advocating for safe breastfeeding in that gray area that we discussed previously. Wide variety of providers within these different medical groups, representing 3 groups, over 20 providers, in addition to their different personal perspectives and knowledge base. And a reliance on timing of test results for the maternal urine toxicology test versus the infant core testing to determine safety. So we concluded that the individualized breastfeeding plan was difficult to implement and needed a better strategy for better and earlier communication of the substance-exposed newborn across the delivery experience. So this led us to the formation of the BPA, or Best Practice Alert, that Colleen has worked really hard on developing in the last couple months and will share with you now.
Okay, thanks, Erica. So we set out to create an actionable best practice advisory in EPIC, and this will alert the pediatric providers that an infant is potentially at risk for in utero substance exposure. Again, this is based off of what the L&D nurse and the mom baby nurse has determined early on from the mom's history. So this BPA will fire for the pediatric provider when a core toxicology screen has been ordered on the infant. And looking at our process mapping, we determined this is the best trigger for this BPA, in that this core toxicology screen is placed in the infant's chart, usually within an hour or 2 following delivery. And again, this is based off of a universal screening that is done on all moms who present to labor and delivery. And so with this BPA, the pediatric provider will be instructed to review the maternal history and then determine the infant's eligibility for breastfeeding. And this can be any pediatric provider. It can be the pediatrician, it can be an NP or a PA or a neonatologist or an NNP in the NICU, whomever is opening that infant's chart. And we will pilot this at all the SEL health hospitals, and that includes 5 hospitals in Colorado and 3 in Montana. Next slide. So the actions that the provider will have to take upon seeing this BPA is that they will have to update the history in the infant's chart, update the problem list, and then ensure that there is an order in place for the NAS assessments to occur. And then most importantly, they need to update the feed order to include breastfeeding or only formula feeding for that infant. They have to acknowledge that they've seen the BPA and accept that they've taken one of these actions. There also is a choice that potentially it may not apply to that infant if upon review of the mom's history, they determine that the infant is not at risk for in utero substance exposure. It also will include a link to the AAP breastfeeding recommendations in substance exposed newborns, and also the Academy of Breastfeeding Medicine link for recommendations will be there as well. And that's reference for the pediatric provider in case it's been some time since they have cared for an infant who's been substance exposed, or they just want to become familiar with the latest recommendations. Next slide. So just moving on to the impact of COVID-19 on ESC and opioid exposed newborns. I know Susan has already shed light on this earlier when she's giving her data update for our CHoSEN collaborative. Like most hospitals at Lutheran, we've not had NICU cuddlers permitted in our hospital since March of 2020. We have also seen an increase in opioid exposed infants during this time. And with this increase in numbers, we also are seeing an increase in infants who are requiring PRN meds and scheduled medication treatment as well. Next slide. So again, looking at the data across the collaborative as a whole, just pointing to this time period here. Percent, and we increased %. Next slide. First, what goes along with that is I've seen infants who've received pharmacologic therapy beginning of this quarter from April to June. It was right around 11, and then we did see up to almost 16 days for that average length of stay. Now we are going to see that come down again. I know across I know out at Lutheran, we've decreased numbers of infants, but also have put more infants on scheduled medication than we have in quite a while. And it's really impactful that we've not had our NICU colors able to come in the hospital to help us out with these infants. Next slide. So also just want to move on and give an update about nursing education. So we are working on creating a case studies file to provide ongoing education. My hope is to get this available through Illuminate so that all of our participating hospitals can have this as a resource. And just to provide to either new nursing staff or existing nursing staff and even medical providers as well, just to review these cases and be more familiar with the utilization of ESC, PRN medication use, and even scheduled medication use. Also, I'm working on creating an ESC poster for nursing review. Recently, it's been identified that sometimes it's still not clear exactly when to perform a team huddle. And also what exactly happens in the middle of the night when you don't have a pediatric provider in-house, and how does that team huddle going to look, and who's involved in that. And so these reminders can be, would be really helpful for our nursing staff. And so I would imagine if that's the case at our hospital, that's something that we'd like to make available to other hospitals as well. And then also we'll be adding in ESC assessment and the yearly skills checkoff for nursing. Again, this has been an area that has been identified that it would be good to review on an annual basis, just to feel really comfortable caring for these infants and families. And then, as I mentioned, we'll make these resources available through Illuminate and CHoSEN Collaborative as well for all hospitals to benefit from. So those are our updates at this point. I hope at a future meeting we can share some of the data of the impact of our breastfeeding BPA at that time. Thanks.
Thank you so much, Erica and Colleen. Really exciting. Next, we'll be hearing from Stephanie Bork, who also is a neonatologist here at the Anschutz Medical Campus. And she'll be talking about the work that she's been doing at Valley View Hospital and Denver Health, focused on the parental experience.
Great, thank you, Susan. Can you all hear me?
Yes, we can hear you.
Okay, great. So I think with all of this information and data that we've been hearing about this morning, I think a key part to this work is really hearing from families themselves. And we'll have the opportunity to do that here in our forum this afternoon. And then in this real key driver, our focus has been on understanding how the experience of parents has been, especially as we've made this transition to more ESC and non-pharmacologic care. You can go to the next slide. So as everyone I think on this call knows, the utilization of the ESC tool and focusing on non-pharm care requires a huge amount of support from both providers and families. And without that sort of buy-in and engagement, it's really difficult to carry out this work and to keep babies who are able to not need routine pharmacologic care sort of in the ESC pathway. And we know from our work here in Colorado that we've been able to decrease our birth length of hospitalization and our length of stay, as well as the need for pharmacologic therapy. But what we don't really fully understand yet are how parents might be impacted by this new approach, and how do they describe their experience during this really critical period of time in their family. You can go to the next slide. So to that end, we are in the process of conducting semi-structured, open-ended qualitative interviews. I'll share a little bit about the interview guide that we've been using. We are seeking to enroll and engage with participants who are parents of infants during or close to that birth hospitalization time period. So we approach them either during the birth hospitalization. We're working on actually introducing this opportunity to families during the prenatal time period when we're able to. And then like everything in our life, we're doing a remote sort of Zoom recorded interview by a qualitative research expert who's housed here on the medical campus. We are working for all of our sites to get compensation approved for participation, just knowing that we value our families' input and feel that it's important to sort of appreciate them for their time and their expertise that they're giving to our collaborative. These interviews, as I mentioned, are recorded. We're then transcribing them and in the process of coding and analyzing our results to then be able to share back the themes that we're generating to the hospitals that are engaged in this work. You can go to the next slide. So as I mentioned, we have an interview guide that really focuses on 3 key time periods, the prenatal time period, the birth hospitalization itself, and then that transition from hospital to home. And so I've highlighted here a couple of questions that we're really interested in gathering data from families around. So the first is on the prenatal standpoint. Did you receive prenatal counseling about the care of your substance exposed infant during pregnancy? And what were those interactions like with your prenatal providers? And then the bulk of the data that we're collecting and the experience that we'd like families to share with us is really how they experience their birth hospitalization. So were you able to stay with your baby? Did you feel welcome in the well baby nursery or the NICU? How was your baby fed in the hospital? And how involved were you in your baby's care? Really getting at the impact of Eat, Sleep, Console and the education that they hopefully have received sort of throughout this process. And then as we think about that transition from hospital to home, some of the questions around discharge, including the sort of sense of preparedness that families may or may not have to take their baby home, and what might have helped or hindered that sense of feeling prepared to make that transition. And then really asking for honest feedback. Were there things that you wished your hospital did differently that would have made your overall experience better, so that we can really learn from these families sort of in the moment? You can go to the next slide. So as we're conducting these interviews, there's a couple of things that have come to light. We're still in the process, and we would love for more families to provide us feedback in this way. But from the individual level, really the importance of prenatal education has been highlighted. And I know we've heard about that through other work being done in the collaborative. Families that didn't understand or know what CHoSEN was about in the prenatal side, I think, have a bit of a more challenging time during that birth hospitalization with a lot going on. They talked a lot about shared decision making. So there was one participant who shared a lot about the back and forth that the providers and the family were able to have. Like, does the baby need a PRN dose of medication? Let me try to feed the baby again. Let me try to swaddle the baby. Really sort of coming together as a group to do what's best for the baby in that moment. From the hospital standpoint, support with ESC implementation has been really key for participants that have shared their feedback with us. So one mom talked a lot about how she learned how to better swaddle her baby from the nurses at the bedside, that they were given a white noise machine to really help create that supportive and calm environment for their infant. In general, I think upfront and open, honest communication is appreciated, understanding expectations. Depending on your hospital policy, you can be expected to be admitted here for this period of time. Here's how we're going to monitor your baby and what we're looking for. And then as we think about sort of the bridge between the hospital and the community, really thinking again about that preparedness for discharge and follow-up. What does it look like as we kind of develop that plan of safe care for that infant to go home? And a number of people have talked a little bit about sort of the referral and the ability to access community resources, including early intervention and nurse-family partnership, as being important for them as they're making that transition to home. You can go to the next slide. So I wanted to share just 2 quotes from stories that we've heard from families. I think it really brings a personal sort of aspect to all the data that we talk about in this collaborative. And so one mom shared that one thing that has been consistent through both of my experiences, I was very surprised at how every staff member, especially the nurses, knew a significant amount about withdrawal, the adverse effects of medication versus no medication. They were very non-biased and very informative, and they were all consistent on what they knew. You can tell the information was accurate. So I think just really highlighting the importance of that bedside education and the communication that we're providing to families every shift that they're interacting with our care team in the hospital. You can go to the next slide. And this I just loved. I just want to say thank you to everybody that you know has helped during this journey. This is a life-changing event. And I'm just thankful to you and to everybody in putting all the ties together, I guess. And I don't know what analogy you'd want to use, but just making this experience so positive and exciting, because it could be very stressful and scary, daunting, but it's not. So I think just highlighting the appreciativeness that the families have for all the work that's being done on the hospital side, and knowing that this is such an important time in a family's life together. You can go to the next slide. So we are in the process of still recruiting and undertaking interviews, both at Denver Health and Valley View. And if there are others on the call, my contact information is in the next slide. I'd love to hear from you. We'd love to engage and sort of learn more about the experience that families might be having at your hospital. We are, kind of ongoing analysis and evaluating themes from these interviews with the idea and hope that we can identify actionable items to really optimize this care, both on the prenatal side during birth hospitalization and with the transition to home. And then CHoSEN is collaborating with CoLab, who is in the process of developing a longitudinal study, which will look a little bit different from this work, but will really be a series of in-depth interviews with birthing individuals who are experiencing prenatal substance use in our state. And so they are actively sort of setting up to recruit adults who are participating in substance use disorder treatment. And this work will include a series of 3 interviews spanning the prenatal time period up to about 6 to 12 months post-delivery. So more to come on that, but again, another avenue and sort of opportunity to learn from our families directly. You can go to the next slide. So my information is here. I'm also happy to take questions at the end of this session, but if your hospital has questions about this or is interested in participating, please do be in touch so that we can make that connection and hear from your families. Thank you.
Fantastic. Thank you so much, Steph. Next, we'll hear from Lauren Bruns, who is a pediatrician at Denver Health and also at the University Hospital. And she'll be sharing with us the work that she's been doing at Denver Health focused on safe discharge and plans of safe care.
Hey, Susan, can you hear me?
Yes, we can hear you.
All right. Well, thank you so much. I'm going to talk just briefly about what we have been working towards in terms of coordinating a safe care discharge plan for our babies at Denver Health, and then Susie Morris will go into the plans of safe care much more extensively later this afternoon. So we can go on to our first slide. For the clinicians who may not know what a plan of safe care is, I wanted to just spend a really brief moment on talking about what the plan of safe care is and where that came from. So a plan of safe care is essentially a tool that's been federally mandated to address the health and substance disorder needs of both the baby and the mother. And they recently kind of expanded the definition of this to include substance use and not necessarily delineating illegal versus legal. So it incorporates all substance use and any baby who is exhibiting withdrawal symptoms. Unfortunately, they don't, the Act doesn't go into describing withdrawal symptoms or elaborating on substance use, but does kind of delineate the fact that the plan of safe care needs to address the immediate safety needs of both the infant who is affected, as well as the health and safety of that affected family or care provider. And this was instituted as part of the CARA, which is an amendment to CAPTA, which I'll explain here briefly, but it's part of Title V, Section 503 of that Act. So I'll explain that in the next slide. So briefly, and we can move forward. This I found interesting that that this is actually you can go onto the government website and actually read what this act looks like. And we can go to the next slide, and it breaks up kind of the different sections of Title V, and 503 being the mandate for infant of plan of safe care. So on the next slide, I just briefly review what CAPTA is. And CAPTA was the Child Abuse and Treatment Act that was instituted back in 1974, and really addresses the treatment and investigation and care of children who are victims of abuse and neglect. In 2016, as a response to the opioid epidemic, President Obama signed the CARA Act, which is the Comprehensive Addiction Recovery Act. And the goal of that being to coordinate a response to the opioid epidemic that addresses prevention, treatment, recovery, and also goes into criminal justice reform in overdose reversal. And so the Plan of Safe Care is part of that CARA Act that was signed by President Obama in 2016. So the next slide will kind of just give us an overview of how did the Plan of Safe Care fit into this. And so, like I said, the Plan of Safe Care is addressed in Section 503 of CARA, that amendment to CAPTA, and essentially it, like we talked about earlier, broadens the definition of substance abuse to include both illicit and legal substances, and delineates the fact that that Plan of Safe Care needs to address the infant's needs as well as the caregiver needs. So recognizing that to take good care of this infant who's affected by substance abuse, we also need to take care of the caregiver who is a substance user. And along with that, it's mandated that that Health and Human Services disseminates information about state planning and the practices related to plans of safe care, as well as you guys can see there's some of the data from that. So on the next slide, we will kind of talk about what a plan of safe care entails. And again, Susie Morris, who's going to be speaking later, will speak more to this. But essentially, it's not clearly delineated in this act, but simply just says that it has to address the needs of the baby and the caregiver immediately, but also has to address the substance use treatment of the caregiver, and needs to be developed with input from those parents, as well as providers, both prenatal and pediatric providers, and county and community agencies. So really kind of needs to be a multidisciplinary approach to caring for that baby and that affected caregiver. So on the next slide, this is a slide out of Florida that essentially kind of delineates what may be considered kind of guidance for effective plans of safe care, and y'all can read that. But essentially, kind of the most important aspects are these are family focused, and that they are taking a multidisciplinary approach and addressing both the physical, social, emotional, and kind of socioeconomic health safety needs of both the infant and the context in which that infant will be living, so the caregivers as well. So as we advance to the next slide, we can kind of see that, and we can keep going, that states and institutions have each interpreted this quite differently. So for example, Kansas has a plan of safe care that is 2 pages, and as you can see, it doesn't, we can go to the next slide as well. It doesn't actually really delineate anything specifically, whereas if we advance to the next slide, this is the plan of safe care out of Delaware, and I believe this is like 14 pages, and goes into quite a bit of detail regarding the context in which that baby is living. So all the caregivers at home, all of the baby's symptoms, kind of what treatments a mom has received. So it is quite extensive. Like I said, 14 pages that would be fairly time and resource intensive. And then lastly, this was an example out of New Hampshire, and that one is just a couple of pages long, and is a little bit more similar to Kansas. So at Denver Health, so in Colorado, Susie Morris again will go into more of the data, but one of the things that plans of safe care address is that we give a warm handoff to the PCP at time of discharge. And as we've discussed earlier in today, the kind of the importance of early intervention. And as you can see, we have gotten better in terms of our early intervention referrals for our opioid-exposed neonates amongst our CHoSEN collaborative reporting hospitals from 2018 to 2020. But the reported completion of a PCP handoff, which is a very important part of that plan of safe care as we transition a baby from an inpatient setting to an outpatient setting, we are still not entirely there. So as we advance, I'll kind of talk a little bit about what we've done at Denver Health. So Denver Health, for those of you who are not familiar, as Susan has pointed out earlier, is our safety net community hospital. We have more than 3,000 deliveries a year, and our care network is composed of 8 family medicine clinics, as well as a women's care center. So some of our the moms who are coming to deliver at Denver Health are cared for in our family medicine clinics, whereas others are cared for at Denver Health and the Women's Care Center. Denver Health does a wonderful job in addressing our families affected by substance use, and have several substance use treatment programs that you can see there. And we care for quite a bit of substance exposed newborns at Denver Health. And of the hospitals reporting to CHoSEN, Denver Health has consistently cared for over 10% of those babies. So moving forward, what we have been working to implement at Denver Health is essentially both prenatal and postnatal plan of safe care that can be accessed and updated by multiple care providers. And as I think Susan mentioned before, Colleen is one of our EPIC gurus, and had mentioned she had attended an EPIC conference recently that talked about a clinical care pathway that can actually be created in a chart and can follow a baby from an inpatient stay to an outpatient stay, and kind of allows for tracking of follow-up needs and things like that for infants. Unfortunately, and rather that can be applied to any patient population, but what obviously we would use for it is our infant population. Unfortunately, to build that out in EPIC is quite an undertaking, as I'm sure many of our care providers know, that that changing things in EPIC is an uphill battle. So while we are working to kind of implement that at Denver Health, what we've done is create a little smart phrase, or EPIC dot phrase. And for those of you who don't use EPIC, that is our medical record system, and it essentially allows us to use a shorthand to create a note in this baby's medical record that, as you can see here, will allow providers to go in and complete information that then will be saved in a note in that patient's chart. So what we are hoping to implement over the next, by the end of this calendar year, is the rollout of this plan of safe care that starts prenatally to be completed by our care providers for our mother. And so this allows us to start gathering the data that will be needed and the information that will be needed to ensure a safe plan of discharge for mom and baby, and begin that education process, begin that information gathering process in pregnancy. So here, this is a screenshot from EPIC, and shows you what our prenatal or our care providers for mom would start to fill out in a mom who has a history of substance use. So you can see the patient identifiers; those would be auto-populated, and then the provider who's completing this, which would be mom's, family medicine doc or midwife or OB, can go through and select any substances that mom has used during her or prior to pregnancy. And then in the next slide goes into any of the substances that mom has used during pregnancy. It delineates if she is in any current substance use treatment, and as we move forward, it kind of goes into some of her socioeconomic confounders. So in the next slide, it addresses a history of if mom has any social stressors like depression, history of domestic violence, incarceration, which you can all see in the next slide. Cassie, if you want to move forward. And then goes into any current medical problems mom has, any current pregnancy complications. And then in the next slide, it again kind of delineates what mom has had in terms of her OB care, and then education regarding the expected course of the baby, and starts to kind of take inventory of what mom's feeding preferences will be, and I think kind of helps address earlier rather than at the time of delivery what mom's resources currently are. And then in the very last part of that, it gives an area to, in the next slide, has any of the relevant referrals that mom would be eligible for, is currently engaged in, or could potentially be indicated during her pregnancy and then after delivery. So our goal for that, and again, that has not been rolled out yet, but is to encourage our prenatal providers for mom to start taking inventory of these things, getting this information documented. And I think that will also kind of help foster an environment to begin and kind of encourage education regarding the care of the baby and what mom will expect during her hospitalization and then postnatally. And then finally, what we are working for to implement at the time of infant's hospitalization and discharge is this postnatal care plan that's more relevant to the baby. And again, similarly, this can be imported into a note in baby's chart that auto-populates that information up at the top, kind of the demographics, and really details what the infant's course was, what substances that infant was affected by. And then Cassie, in the next slide, lists what the household members, so who will that baby be discharged to, who were some emergency contacts, have we assessed the adequacy of that home environment, and then in the next slide goes into, again, kind of a continuation of any of the relevant referrals for that baby. And as you can see, it includes making sure that that early intervention services has been addressed. If there is a CPS referral indicated, has that been addressed, and things like that. So in the final slide, that ensures that the family has been educated, that we have done a warm handoff with the PCP, and that the plan of safe care was documented with mom. So in our last slide, as has been discussed, there have been by multiple other providers that there are always challenges in implementation of things. And so one of the things that we've encountered at Denver Health, and I sort of alluded to this earlier, is the ability to create a living document. So that clinical care pathway that I had said Colleen had heard about at the EPIC meeting would kind of allow multiple providers to update this information during the course of a pregnancy and then after delivery. Until that is implemented, we're sort of stuck with a note that that would have to be updated at every visit or as information is gathered. And as you guys can tell, kind of the background and the information that goes into a plan of safe care is it requires the input and the expertise of multiple different providers. So OBGYN, our addiction medicine specialists, the pediatrics team, our social workers, our bedside nurses. So having the ability to kind of collaborate and allow multiple people to make input into that in a hospital setting. And then it is at least time intensive in terms of education, assessing for mom's needs, making referrals, and a lot of that falls on our social workers, and then making sure who is going to take ownership of this document. So does the pediatric team take ownership because we are ultimately discharging the baby? Is that something that that our social workers should work on, but they already have quite a full plate? So I think, and again, Susie will talk about what the plan of safe care that they've been developing at the state level looks like, but at Denver Health, these are kind of the things that we have, some of the barriers that we have run into. And I do think that by creating this document and utilizing this, at least for right now, from a prenatal and postnatal standpoint, that will certainly create a much better and more thorough kind of repository of information that then can be utilized for the state level plan of safe care that Susie will talk about, that'll be completed by some of our child welfare workers. So I think this kind of goes into some of the things that we hope to work on. And I talked about that care pathway that we would like to integrate, and hopefully working with our family medicine providers in the future who will some of our family medicine writers are also addiction medicine specialists, so working with them to potentially care for mom and baby after discharge to kind of get a more comprehensive care of that couplet, and then improving the prenatal education around the plan of safe care and expectations during the nursery course.
Great, thanks so much, Lauren. Last but not least, we'll be hearing from Susan Lipinski and Lisa Becker from Presbyterian St. Luke's Medical Center about their work on the AIM OUD bundle.
Good morning. Thank you for the opportunity to tell a little bit about our experience over the past few months implementing this new bundle. We can move on to the first slide. So Presbyterian St. Luke's, for those who aren't familiar with it, is located right in downtown Denver. We do about 1,400 deliveries per year. And in addition to our deliveries, we average about 50 antepartum admissions per month. Within our labor and delivery unit, we have multiple private practice groups that provide general OB care as well as many outreach clinics. We also have a large maternal fetal medicine group who provides very specialized antepartum care, and we receive transports to our hospital from all corners of Colorado, as well as parts of Nebraska, Wyoming, Kansas, and Montana. So beyond just Colorado, we have a lot of experience with patients that aren't maybe exposed to this in their own home states. Our NICU at Rocky Mountain Hospital for Children has 84 beds, which is one of the largest in the state. And that NICU has about 65 admissions per month. So we also get many moms whose babies are transferred to that hospital for postpartum care so that they could be near their infants. So we were approached, both Dr. Becker and I, in July about beginning a rollout for this opioid use bundle involving better screening using a validated model, as well as brief interventions and referrals for treatment. We've been doing this, but not in a consistent basis at our hospital. So we can go on to the next slide. As we started, we really thought we ought to know where we were so we could see where we needed to go. And so we took all admissions and triage patients from August 1st to August 14th, which was 59 patients. We took a look in our electronic medical record, and we are an HCA hospital, so we are using Meditech, which isn't quite as plastic as programs like Cerner and Epic to allow us to start chart reviews and smart advisories, but we were able to look through at nursing admission documentation as well as physician H&Ps and identified that there were, of the 59 patients, about 9 that had no screening documented either by nursing or physicians, as well as identify who had had tox screens and whether any interventions or referrals were documented. And of course, this is a retrospective, so we missed a lot of people who may have had screening that just wasn't documented. Looking at those, fairly high number that were getting screened, but the questions in the admissions process that were for screening were just the generic, any use of alcohol during the pregnancy, any use of drugs, any use of tobacco products. So it was not a validated tool, and it didn't really go in depth. It was really a yes or no. For anyone who admitted to use of substances or those with other triggers such as limited prenatal care or no prenatal care, then urine tox screens were done. And so we had 6 positive screens. At least 2 of those were only marijuana positive, no other drugs. And 5 of those 6 had urine tox screens done. At no point could we find any documentation of any brief interventions with those patients. Of those who had positive screens, we could identify that case management was involved. Those with limited or no prenatal care had case management involved, but there didn't seem to be a consistency or a process for this. So going from there, knowing where we were starting allowed us to start determining what steps did we need to take to really implement this bundle effectively. And the first is the implementation of a validated screening tool. And so once we had identified a tool to use, we then had to work with our Meditech IT to update our electronic health record to allow this screening tool to appear within our admission questions that the nurses are asking. This includes those safety questions and ones that are asked to every single admission to the hospital, but these will be tailored for our labor and delivery unit admissions. Once those are built in, then the plan is for nursing to do this with their admission, but to make sure there's always a trigger for physicians to be notified when there's a positive screen. And then the next step is, of course, some education about this process to all of the physicians who are doing deliveries, both the private practice, the hospitalists, and the high-risk OB physicians on the unit, to make sure that they know what the expectation is, as well as have education about the process of the brief intervention and education about implicit bias to help make sure that this is being done in a very objective way as opposed to subjective way it's been done in the past. And then creating the necessary steps to make sure that there's documentation of this process, because it may well have been happening in the past, but without documentation, it's hard to know. So we can move on to the next. So we began auditing in August, began identifying areas and what we need to do in late August, identified a validated screening tool, and begun the process. As anyone who works in hospitals know, sending something to IT to get it programmed in is not a quick process. So we're still waiting for this to go live within our electronic health record. We're starting to make sure nurses understand the expectation with the implementation. And in November, we're going to approach the OB department so that all physicians know what the expectation is and begin those educational processes. So physicians feel like when they're told a screen is positive, what they need to do. At this time, pretty much everyone's just asking for a urine tox screen and there's no real intervention occurring. So November into December, we'll begin that process of educating about how to have a meaningful intervention. We can move on to the next slide. And so really the true launch and the true impact of this is not going to be seen until 2021. And our goal is, by making this a part of the admission intake on the medical record, to have 100% screening rate. At the initiation, we are not making it a hard stop, so you could skip those questions. If we start to see that becomes a problem, then it could be created as a hard stop, requiring those to be answered before moving on. And end of 2020 into early 2021, there's going to be a lot of education with providers about the brief intervention process. And the hope is that by middle of 20 to 21 is to have the full AIM OUD bundled implemented and just a routine part of our care. Can go on to the next slide. So just in the initial first months, we've really learned a lot about this process and what we do well and what we do poorly. And it definitely seems that as you went through the chart review, nursing documentation on having asked the questions was much, much better than physician documentation. And our guess is that's because the nurses are doing a better job of actually asking the questions, and we're simply taking their answers and going from there. We've not had consistent interventions in both the physician discussion about interventions and referral on. It's been pretty ad hoc depending on who was caring for that patient. The screening has been done primarily as a determination, does somebody get a urine tox screen or a cord tox screen? And often that has limited provider interaction other than just to ask permission to do the urine tox screen. So we really want to get providers more involved in that process. And some of this interaction may be taking place with the private physicians in their clinic evaluations of the patients. But since a large majority of our patients are coming in from other providers, even out of state, we're starting from scratch when they come to our hospital. And we need to really make sure as we roll this out that this approach is really partnering with the patient so that we can start helping them to make the changes that they want to make, as opposed to just being punitive. Answer this question, we're going to do a tox screen, it's going to check the cord, and really trying to make it a facilitating change as opposed to just a testing and referral to CPS. So we're very early in this process. We're still learning a lot. I've appreciated hearing everyone else's experience with their programming, because it's showed me a lot of areas we need to really incorporate into ours. So thank you so much for the time.
Thank you so much. We have a few minutes before lunch for questions, so please feel free to unmute yourselves or chat in a question. There was one question here related to plans of safe care, but also the addition of maternal information onto the infant's medical records. And so the question is, are there any implications for listing mom's medical or / treatment info into the baby's chart? And perhaps more broadly, you know, we are very much committed to thinking of the maternal infant group as truly a dyad that requires attention as a dyad. And so what does that mean when there's documentation of the mom in baby and vice versa? And beyond the speakers for the hospital updates, if there are experts who are on the call right now, please do jump in. So given the silence, it's unclear if there are technical issues or people are at a loss for how to reply to this question. And it is a difficult issue. You know, and there was another point highlighted by Meg Kirkley from Denver Health, where she commented that there is a new federal open notes requirement where families in real time can access electronic medical records. And so if there is maternal or some other family member information recorded in the infant's chart, then the father or some other family member who has access to the records could see that information. And so I think these are things that still need to be worked out. Let's see here, there are some responses coming in here. Lauren, if you'd like to unmute yourself and respond, that would be great.
Hey, sorry guys. Yeah, so I think it looks like Camille had just messaged me on what the what open notes means, and that's essentially the ability to, like Susan, you were saying, anyone who has access to that baby's chart. So the My Chart setting that's in Epic, anyone who has access to that baby's has My Chart privileges would be able to see notes that are in that baby's chart.
So I think at this point, for many of the clinicians, I and probably many others don't yet know how we're going to approach this, you know, with what caution and what protocols and processes will be in place to protect potentially sensitive information of one parent from the other if there are extenuating circumstances within that family. So certainly something that we have to think about.
And the discussion has come up of, we have, and I'm sure as many clinicians have experienced, that there are babies who are born to mothers who are experiencing domestic violence by the father of the child, and how do we document that in infant's chart so that social workers and the outpatient pediatrician are aware of that, but that is not something that would maybe that the father could see and be influenced by that. And we're still trying to figure out how to navigate situations such as those. And certainly we're always encouraging our residents and providers to use only kind of objective and professional means of documenting kind of sensitive situations, but particularly the setting of domestic violence or infectious diseases such as HSV or HIV that the mom has not disclosed to the father are situations that we'll kind of have to navigate in the future, and are certainly kind of posing a new challenge.
All right, other questions? All right. Well, if during lunch you all have questions, please feel free to chat them in, and our speakers will try to answer them in real time during the chat. So we are now at our lunch/yoga break. During this time, if you feel so inspired, you can submit your reflections on what is feeling most motivating about what you've learned so far today by going to the following link. There you go, and Cassie has shared that. So feel free to take a break, turn off your cameras if you'd like. And the yoga session with Sarah will start at 12:15. And then at 12:30, we'll pick back up with our lived experience session.